everyone, welcome to Tract. This is Pack 365. Myself Srija. Today in this session, you're going to learn about CPT coding guidelines under surgery section of Digestive System. So this session introduces you the Digestive System section of the CPT code book and it explains how the section is organized. So CPT codes 40,490 to 49,999, they cover the procedures of the digestive system. So the section is organized anatomically starting from mouth to anus. So each anatomic area has its own code range. So always locate the anatomical subsection first, then choose the procedure code. So here are some important notes, subheadings and headings. So each digestive system subsection has headings which include the main anatomical area and subheadings, so which has a specific structures or procedures. So subsections are marked with an asterisk symbol which have a special coding rules. For example, vestibule of mouth. So it has a special instructions that must be read before coding. So special instructions appear before the code listings. They apply only to that subsection. So ignoring these notes always it gives an error. So code order versus numeric order. So codes are listed as they appear anatomically or not always in the numeric order. So some codes may seem out of sequence and some may appear again in another subsection. So never code by number alone. Always code by anatomy as well as by description. So what are the subsections in digestive system? So the first subsection is lips. So the code ranges are from 40,490 to 799. So they include the procedures like biopsy of lip, excision of lip, and also the repair of lip defects. Second is vestibule of mouth. So this is the area between lips or cheeks and also the teeth. So here there is an asterisk. So that means it denotes some special rules can be applied whenever coding the vestibule of mouth procedures. So what are the common procedures under this category? Incision and drainage and also lesion excision. Next is tongue and floor of mouth. The code ranges are 41,000 to 41,599. So they include the tongue biopsy, partial glossectomy and also the ranular excision. Dento-alveolar structures. So it includes alveolar, ridge, gingiva and also tooth supporting structures. So procedures related to abscess drainage, bone smoothing and also alveoloplasty. Palate and uvula. The code ranges are 42,000 to 42,299. So they include the procedures like uvulectomy, cleft palate repair and also palatal revision excision. Salivary glands and ducts. So they include the different types of salivary glands, parotid, submandibular and sublingual. So the procedures such as ciliolith removal, duct repair and also gland excision. And there are also some more subsections, pharynx, adenoids and tonsils. So they include the procedures like pharynx, procedures on pharynx, tonsils, adenoids. So common procedures like tonsillectomy, adenoidectomy and also pharyngeal biopsies. So these are not the digestive system codes, not respiratory, even though they relate to breathing. And esophagus, they include esophagoscopy, esophageal dilation, foreign body removal, and also repair of some esophageal strictures. Stomach, the code ranges are 43,500 to 43,999. So code stomach, it includes gastroscopy, gastric biopsy, ulcer repair, partial or total gastrectomy. So you have to always check whether the procedure is an open or laparoscopic approach, whether it's a diagnostic procedure or a surgical procedure. And intestines except rectum. So this includes small intestine and large intestine excluding the rectum. So common procedures will be resection, anastomosis and also repair of the obstruction. So rectum is coded separately. And next, Meckel's diverticulum and the mesentery. So they include the removal of Meckel's diverticulum and also the procedures on the intestinal mesentery. Appendix. So appendix codes are from 44,900 to 979. They include the procedures like appendectomy, the both open and laparoscopic approaches, and they consist of complicated versus uncomplicated cases. Colon and rectum. So they include colonoscopy, colectomy, protectomy, and rectal repair. So colonoscopy codes often tested. So whether they are diagnostic versus therapeutic matters here. And anus, they include the hemorrhoid procedures, anal fissure repair, and sphincterectomy. So the code ranges are from 46,020 to 46,999. Liver. So liver, it includes liver biopsy, partial hepatectomy, and also trauma repair. Biliary tract. So always remember biliary tract includes gallbladders as well as the bile ducts. So what are the common procedures here? Cholecystectomy and also ERCP. And pancreas 48,000 to 48,999. So pancreas include the procedures of pancreatectomy, drainage of pancreatic pseudocyst, trauma repair. So complex procedures have high relatable value units. And next is the last one, abdomen, peritoneum and omentum. So these procedures, they include exploratory laparotomy, peritoneal biopsy, anesthesiolysis and also some hernia related abdominal procedures. So often it is used when multiple organs are involved. And the right side you can see the picture of the organs of the digestive system: mouth, liver, gallbladder, appendix, salivary glands, esophagus, stomach, pancreas, large intestine, small intestine, rectum and anus. So what is the procedures of digestive system? So the first procedure is endoscopy. So what do you mean by endoscopy? So what is a general CPT rule about this bleeding? So when bleeding occurs as a result of an endoscopic procedure, the control of bleeding is not reported separately during the same operative session. So what does this mean? So this means if bleeding happens because of the endoscopy itself, for example, biopsy causes bleeding and the physician controls it during the same session, you do not code an additional control of bleeding CPT code. So control of bleeding is always bundled into the primary endoscopic procedure unless bleeding was pre-existing and unrelated. Esophagoscopy. So what do you mean by esophagoscopy? So it includes the examination from the cricopharyngeus muscle, which is also called as the upper esophageal sphincter. So down to and including the gastroesophageal junction. So this may also include the proximal stomach examination via the retroflexion whenever it is performed. So cricopharyngeus muscle means it's an upper limit, whereas GE junction, it's an lower limit. So retroflexion, it is nothing but it's a scope which is bent backward to view the upper stomach. So seeing part of the stomach does not automatically make it an esophagoscopy. And retroflexion is an important concept here. It means the endoscopic tip is turned backward inside the stomach. It always allows the visualization of cardia, fundus, which are the parts of the stomach, and also the gastroesophageal junction from below. Next topic is esophagogastroduodenoscopy, EGD. So EGD, it includes examination of esophagus, stomach and duodenum. So all three must be examined to code an EGD CPT code. So CPT wording, it always emphasizes the esophagus from cricopharyngeus muscle to GE junction. It includes the proximal stomach via retroflexion plus actual advancement into stomach and duodenum. So if there is no duodenum, you should not code EGD. So what are the CPT code ranges referenced? So the common EGD related CPT codes such as 43,200 to 43,232 series. So these cover diagnostic EGD, biopsy, control of bleeding, dilation, removal of foreign body, injection therapy. So always read how the provider documented whether it is a diagnostic versus therapeutic, with or without biopsy, single versus multiple interventions. So here a picture of EGD. You can see the endoscope is advanced to the stomach and also the duodenum. So incomplete EGD. So what is normally expected in EGD? So a complete EGD examines esophagus, stomach and duodenum. So if the duodenum is not examined, the procedure is considered as incomplete. So when is duodenum not examined? Clinically not required. For example, indication limited to stomach. Unsafe to proceed, such as large amount of retained gastric contents or whether there is a bleeding or there is a patient instability. So now how to report this incomplete EGD? You append a modifier. So modifier 52 for reduced services. So in this duodenum intentionally not examined. So there is no plan to report the exam later. So for example, EGD stopped at stomach because of duodenal exam is not clinically needed. And modify 53. You have to assign this for discontinued procedure. So procedure stopped due to patient safety. Repeat examination is planned. So for example, duodenum not examined due to poor visualization. So patient will return for repeat EGD. So in this case, you have to assign modifier 53. So 53 is nothing but it is stopped early due to problem. Whereas 52, it is reduced but it is finished. And ERCP. So what is ERCP? Endoscopic retrograde cholangiopancreatography. So what is an ERCP? It's a specialized endoscopic procedure to diagnose and treat the biliary as well as pancreatic duct disorders. So it always combines endoscopy plus fluoroscopy. So now diagnostic versus therapeutic ERCP. So what is the code for diagnostic ERCP? 4300-260. So it describes visualization of the bile duct or pancreatic duct only. Whereas therapeutic ERCP, the codes from 403261 to 43265 and 43274 to 43278. So what is an important coding rule here? Do not separately code diagnostic ERCP 43260 code when a therapeutic ERCP is performed. So here is a guide wire rule. So guide wire passage is included, so never code it as separately. So when is ERCP considered complete? At least one ductal system is visualized, either biliary duct system or pancreatic duct system. So even if only one duct is seen, so procedure is considered as incomplete. So next is failed or attempted ERCP. So if ERCP is attempted but cannulation fails, there is no duct is visualized. So then you have to report unsuccessful ERCP codes such as 43,235 to 259, 43,266 and 43,270. ERCP with stents and balloon dissection. So CPT codes 43,274 for stent placement, 43,275 for stent removal, 276 for stent exchange and 277 for balloon dilation. So this apply to the pancreatic duct as well as the biliary duct. So do not confuse with percutaneous biliary procedures. So percutaneous biliary catheter codes are 47,490 to 47,544. So ERCP is endoscopic, but it is not a percutaneous approach. So which ducts can be reported in ERCP? So what are the ducts? For reporting coding purposes, ERCP procedures like stenting, stent exchange or balloon dilation can be performed in the following ducts. One is pancreatic system, the major pancreatic duct and minor pancreatic duct. So the other is biliary tree, the common bile duct CBD and the right hepatic duct, left hepatic duct and cystic duct or gallbladder. So all of these ducts are considered part of the pancreatico-biliary system. So ERCP codes apply to any of them. So now, how is ERCP with stent placement and balloon dilation done? So what is an important rule? If a stent is placed in a duct, any balloon dilation done in the same duct is included. So do not code balloon dilation separately because balloon dilation is considered a part of preparing the duct for stent placement. So stent placement is a bundle service. Balloon dilation in the duct has no extra code. So more than one stent is placed in the same day in the same session. So sometimes stents are placed in different ducts. For example, CBD plus pancreatic duct or two stents side by side are placed in the same duct. So how to code in this scenario? So first you have to assign 43,274 code for the first stent placement and you have to assign 43,274 plus modifier 59 for each additional stent placement. So modifier 59 is used to show a distinct procedural service as well as a different duct or a separate stent placement. So ERCP with stent exchange, nothing but a replacement. So what is a stent exchange? Old stent is removed and new stent is placed in the same session. So in these cases, you have to assign 43,276 for initial stent exchange and 43,276 with modifier 59 for each additional stent exchange during the same session. So each extra exchange gives you the same code plus modifier 59. So here is a diagram which shows you the endoscope passing through the esophagus, then stomach and then into duodenum. So it's a cannulation of bile duct as well as the pancreatic duct. So you can also see the location of gallbladder and pancreas and also the common bile duct in this picture. So this helps you to visualize how ERCP accesses the ducts against the flow. So why multiple ducts may be treated in one session. Okay. So next is ERCP balloon dilation, bariatric surgery and also the laparoscopy. So ERCP with balloon dilation in more than one duct. So what does this mean? So during the same ERCP session, the physician performs balloon dilation in more than one duct such as common bile duct plus hepatic duct, biliary duct plus pancreatic duct. So what is the coding rule here? Report the initial balloon dilation code, append modifier 59 to the subsequent balloon dilation. So modifier 59 indicates distinct procedural service, different duct treated during the same session. So same duct, same session, there is no need of a modifier. If it's a different duct within the same session, you have to assign modifier 59. So what is bariatric surgery? So what organs are involved here? So bariatric surgery, it refers to procedures done to treat the morbid obesity by altering the digestive tract. So what are the organs involved? Stomach, duodenum, jejunum and ileum. So why this matters in coding? So procedures may be restrictive. For example, usage of the gastric band, safe gastrectomy and also the malabsorptive combination procedures. So understanding anatomy helps you to determine the correct CPT code and also the surgical approach. And coming to laparoscopy. Laparoscopy, we have surgical and also diagnostic. So here is a key rule for you. Surgical laparoscopy, it always includes the diagnostic laparoscopy. So what is the code for diagnostic laparoscopy? CPT code 49320. So this is only reported only when it is done alone. For example, abdominal exploration only. There is no definitive surgical intervention. So do not report 49320 code when a surgical laparoscopic procedure is performed in the same session. So surgical laparoscopy, it always includes visualization, exploration, definitive surgical treatment and also the diagnostic laparoscopy, it becomes bundled into the surgical procedure. Adjustable gastric band. So what is the post-operative care rule for this? So what is included in the surgical package? So after gastric resection, using an adjustable gastric band, so the global surgical package includes routine post-operative visits and also the subsequent band adjustments. So what is a band adjustment now? It's a changing band diameter by injecting the fluid or aspirating the fluid. So it is done via the subcutaneous port. So what is the important coding rule here? These routine adjustments, these are not separately billable. They are included in the global period. So this is about the bariatric surgery and laparoscopy. And next is excision. So what is excision? What is an intestinal allotransplantation? So intestinal allotransplantation, it's a transplantation of the intestine from a donor to a recipient. So it is usually done for a short bowel syndrome, intestinal failure and severe malabsorption. So this is a multi-stage procedure and each stage has its own CPT coding. So what are the three distinct components of a physician work? Donor enterectomy. So it is a removal of the intestine. So this involves the harvesting the intestinal graft and preserving it for transplantation. So the first is cadaver donor enterectomy, the CPT code 44132. So it includes removal of intestine from a deceased donor, cold perfusion with preservation solution and cold maintenance of the graft. So second is living donor enterectomy. CPT code 44,133. So this includes harvesting the intestine from living donor as well as cold preservation of the graft and also giving care of the donor patient. So living donor procedures always include donor care. So coding differs from the cadaver donor. And second step is backbench work, which is a graft preparation. So what is a backbench work? The work done outside the body, preparing the intestine graft before the implantation. So it always includes the mobilization of the superior mesenteric artery and vein, and also it includes the fashioning vessels for connection to the recipient. So the CPD codes are 44,715 for standard preparation and 44,720 to 721. It includes the additional reconstruction, that is arterial and or venous anastomosis. So backbench procedures, they are separately reportable from donor and recipient surgeries. So the third step is recipient intestinal allotransplantation. So what does this include? Implantation of the intestinal allograft. So there is a possible recipient enterectomy, removal of the diseased intestine. So post-operative care of the recipient is included here. So the CPD codes 44,135 and 136. So these codes represent the final and most complex stage of the transplant surgery. So this is about the intestinal allotransplantation. So next procedure is colectomy partial. So what is a partial colectomy? Only a segment of the colon is removed. So remaining ends are reconnected, that is anastomosis. So CPT code for partial colectomy is 44,140. So the clinical examples are colon cancer, diverticular disease, and Crohn's disease. So if an anastomosis is performed, it is not a colostomy. If bowel ends are not reconnected, then different codes apply here. So next is stromal endoscopy. So what is a proctosigmoidoscopy? So these are the definitions under endoscopy. Stromal. So proctosigmoidoscopy, what is it? It's an examination of rectum. It may include portion of the sigmoid colon. So there will be a shorter scope. It is of a limited depth. It is often done for rectal bleeding, hemorrhoids and distal lesions. Second is sigmoidoscopy. It is an examination of entire rectum, sigmoid colon. It may include a part of descending colon. And it goes farther than a proctosigmoidoscopy. It does not examine the entire colon. And colonoscopy. It's an examination of the entire colon from rectum to colon. So it may include terminal ileum and small intestine near a surgical anastomosis. So it's very gold standard for colon cancer screening and as well as the polyp detection. So colonoscopy through stoma. So when is it done? A patient has a colostomy. Scope is inserted through the stoma but not the rectum. So what it is examined here? Colon from colostomy stoma to the cecum or colon to small intestine anastomosis. So it may include the terminal ileum. So same colonoscopy, there is a different entry route here. And incomplete colonoscopy. Coding rule is a patient is scheduled and prepped for a total colonoscopy. Physician cannot reach the cecum due to tortoise colon, maybe obstruction or maybe patient intolerance or bleeding. So how would you code? So if it's a standard colonoscopy, you have to assign the code 45,378 with modifier 53. If it's colonoscopy through stoma, you have to assign 44,388 code with modifier 53. So modifier 53 is for discontinued procedures. So this is allotted due to unforeseen circumstances and also it requires a clear documentation. Incomplete therapeutic colonoscopy. So what does this mean? So if a therapeutic colonoscopy is performed, for example, biopsy, polypectomy, control of bleeding, but the scope does not reach the cecum or colon, a small intestine anastomosis. So then the procedure is incomplete here. So what are the CPT codes involved? 45380 for biopsy, 45381 for directed submucosal injection, and 45382 for removal by hot biopsy, and 45388 for ablation, 45398 for endoscopic mucosal resection. So now how to report these? So report the appropriate therapeutic CPT code. You have to append modifier 52 for reduced services, and also it provides a clear documentation. So modifier 52 is used when the procedure is partially completed, reduction was planned or accepted, and it is not stopped due to emergency. And the contrast with modifier 53. So 53 is assigned for the procedure discontinued due to unexpected circumstances, whereas modifier 52, it is reduced but completed to the extent possible. This is the difference between modifier 52 and 53. So then, percutaneous biliary procedures. So what are percutaneous biliary procedures? So the access to the biliary tree through the skin, and the common approaches are transhepatic and transcholecystic. So these procedures are image guided, ultrasound, fluoroscopy. So what are the CPT code ranges? 47490 and 4747531 to 47544. Diagnostic cholangiography. It's an injection of contrast dye into the bile ducts. So imaging to evaluate the obstruction, stones, strictures and leaks. So diagnostic cholangiography, it is typically performed with percutaneous biliary procedures. So they are included diagnostic codes. So diagnostic cholangiography is included in 47490, then 47533 to 47541. So they are not separately reportable with these procedures. So codes 47531 and 532. So what are the special rules applied for these codes? So what do these codes represent? 47531 for percutaneous diagnostic cholangiography and 47532 for percutaneous diagnostic cholangiography with access to biliary system with the help of needle or catheter. So what are the included services here? Contrast injection, radiological supervision and interpretation, and imaging guidance, ultrasound and a fluoroscopy. So what is the important bundling rule here? You should not report 47531 or 47532 with 47533 to 541 because diagnostic imaging is already included in the therapeutic biliary procedures. So this is how percutaneous biliary procedures are assigned. Then coming to repair. So repair includes hernioplasty, herniorrhaphy and herniotomy. So what is a hernia first? A hernia, it occurs when an organ or tissue, usually intestine, protrudes through a weak spot in the abdominal wall. So what is a herniotomy? It is typically done by suturing tissues together. It's a repair of a hernia defect. So there is no mesh used here. It's a traditional repair. Coming to hernioplasty, it's a hernia repair using mesh or a prosthetic material. It reinforces the abdominal wall. It's a most common modern technique. And herniotomy. So herniotomy, it's a removal of the hernia sac. It is often performed in children. It may or may not include the reinforcement. So repair is herniorrhaphy or hernioplasty, whereas herniotomy, it's a sac removal only. So now how hernia repair CPT codes are categorized. So by type of hernia, by initial versus recurrent, by patient age, and also by clinical presentation. So by type of hernia, so codes are primarily selected based upon the anatomical location, whether it's an inguinal hernia, femoral, lumbar, omphaseal, umbilical, epigastric, incisional, anterior abdominal or parastomal. By initial or recurrent. So initially is nothing but first time repair. Recurrent is hernia returns after a prior repair. So recurrent hernias usually have different CPT codes. So based upon by patient age. So some hernia codes differ for children and adults. Based upon clinical presentation. So hernias may be reducible. They can be pushed back manually. They can be incarcerated. They can be trapped. They cannot be reduced. And strangulated means a blood supply is compromised here. So severity increases from reducible to incarcerated and also to strangulated. So strangulated hernia, which we have an extra coding rule. So what happens in strangulation? So this herniated organ loses the blood supply. Tissue may become necrotic and it may require resection or repair of the involved organ. So what is the important coding rule here? Repair of the strangulated hernia is coded separately from excision or repair of the affected organ. So what are the examples of these additional codes? 44120, For resection of the intestine, 54520. For excision of the testis, 58940. For ovarian surgery. So these codes are reported in addition to the hernia repair code. And at the right side, you can see the picture of types of hernias. So here you can see where the types of hernias are located within the human body. So the cross-sectional image shows the skin, abdominal wall defect, herniated intestine and also fat tissue. So this helps you to visualize where the hernia occurs and why the repair is needed. So this is about the guidelines regarding hernioplasty, herniorrhaphy and herniotomy. So this is for today's session. I hope the session has helped you. So in the next session, you're going to learn about the CPT coding guidelines, the surgery guidelines regarding urinary system. Thank you.